Okay, well, welcome everyone to teaching today. I wanted to talk today about the acute management of head injury in children. It's often something that we think the surgeons should manage, but actually pediatric head trauma is very common in emergency departments, in pediatric wards, and it's important for paediatricians and pediatric trainees to have a good understanding of how to manage a child who's got an acute head injury. So we'll run through a case and we'll talk a bit about brain injury in children. Firstly, this is what we'll talk about today. I want you to understand by the end of it the concept of both primary and secondary brain injury. And the two things are different. We can't do too much about the primary brain injury. That happens at the scene of the accident, but we can do something about the prevention of secondary brain injury, and that's really our job, to try to prevent secondary brain injury. I'll explain the Glasgow Coma Score and how it gives us a lot of information, both in terms of prognostically. The Glasgow Coma Score at the time the child is injured can give you a very good understanding of their likely prognosis, their likely outcome, and also following the Glasgow Coma Score can give you a very good understanding of whether a child's improving or not improving. We'll talk briefly through a case, and I'll talk about a trauma systematic approach, which is not too different to the systematic approach to the management of any very sick child, with triage and emergency treatment and taking a history and doing an examination, etc. But it does differ in a couple of areas. So we'll talk about a trauma systematic approach. We'll run through some trauma X-rays, because X-rays are available in most locations, even if CT scans aren't available, but X-rays are available, and how in any trauma case then it's important to do a series of X-rays, and I'll show you some abnormalities on those X-rays that might help. We'll talk a bit about neurocritical care monitoring, and even in hospitals where there aren't sophisticated intensive care units, you can still do the basics of neurocritical care monitoring and neurocritical care. And we'll go through that. And then we'll talk a bit about responding to complications and how that requires a multidisciplinary team where you've got the surgeons involved as well. So, okay. Firstly, to understand a bit about head trauma in children, it's important to know the most common causes, and the most common causes in general are pedestrian accidents. So pedestrian accidents where there's no adult supervision at the time of injury. Falls are another important cause of pediatric head trauma. And then the third cause is intentional head trauma, and that occurs more commonly in adolescents who are involved in some degree of violence, and also in small children who are involved in victims of child abuse. And so there are different sorts of head injuries that can occur in children, both from motor vehicle accidents, especially pedestrian accidents, but also children unrestrained in motor vehicles that have an accident. Falls are very common, and intentional head trauma. Most of the accidents occur in settings where there's no adult supervision at the time of the injury, and that's in all childhood accidents. That's a common factor, and a lack of adequate adult supervision. Half of all head injuries are mild, and that's important to know. Half are mild. They're just a level of concussion. A proportion are moderate, and then quite a small proportion are severe. So paediatricians can manage most of the mild and moderate head injuries, and it's important to know how to manage concussion, which is and how to differentiate concussion from a serious head injury that requires more involved management, such as surgical management. So we're going to talk about primary brain injury to start with. And remember, I said primary brain injury is that injury which we can't do much about, apart from advocating for better safety measures, better parental supervision for children, etc. But the primary brain injury has already happened by the time the child arrives at your emergency department or in your hospital. And that can be a number of different types of injuries. And I've shown both the X-rays and the CT scans of different sorts of primary brain injury. And I just, even though uh, perhaps you don't have CT scans in all hospitals, there are certain patterns of CT scan changes on that you can see and can identify different types of primary brain injury. So first of all, skull fractures, which are just evident on X-rays. You can see in this X-ray, these are the normal suture lines, the coronal suture lines, but these two lines here, the two lines that intersect and overlap, it's a linear skull fracture. Now, having a skull fracture doesn't mean you've got an intracranial injury, but it can do. And so any child with a skull fracture certainly needs observation for a period of 8 to 24 hours after their injury to make sure that they don't have an intracranial injury. So that's a primary injury. Another primary brain injury is an extradural hematoma. And if you look at this CT scan, you can see the extradural hematoma, the extracranial hematoma just outside the head. It's just a big hematoma in the soft tissue of the forehead on the left side. And also this child has a cerebral contusion. So this small area of what we call hyperdensity in the left frontal lobe is a cerebral contusion, and you can see that that's the result of that direct trauma to the left frontal region or the left forehead of the child. Then but below that uh, cerebral contusions, and here is these are cerebral contusions with edema. Anything that's bright white is likely to be blood, and you could see in this image at the top the hyperdensity is blood within the brain substance, and you can see here the whiteness which is outside the bone is also blood. That's a subdural hematoma. It's not the classic uh, the classic shape of a subdural hematoma, and that's because there's been a significant frontal contusion as well. So this patient has bilateral frontal contusions with edema and subdural hematoma and some intracranial contusions as well. In the fourth X-ray, the bottom right, this child has bilateral subdural effusions, subdural collections, and there's a small area of whiteness here, which is fresh blood, and then there's a larger area where there's inside the bone and outside the brain, there's a collection of fluid, and that's blood when it first occurs looks bright white like this intracranial hematoma, and then as it ages over days and usually by about a week, then it becomes dark like this, and then eventually it has the appearance of the same CT consistency as the brain itself, so it can be quite hard to see. This is an extradural hematoma that's probably about 5 to 7 days old, and there's been a fresh subdural hematoma as well as that. The other sorts of primary brain injuries include what's called a diffuse axonal injury, where if there's been a force applied to the front of the head or the back of the head, then the brain can shake within the cranial cavity, and there can be extensive bruising and what we call diffuse axonal or shearing forces on the brain itself, and that can lead to often the appearance in a CT scan, for example, is multiple petechial hemorrhages where there's been shearing forces on the brain itself. That sort of diffuse axonal injury is also common in children who've had what we call an acceleration-deceleration force applied to the head. That is, they've hit a blunt object, such as being hit by a car, and their brain shakes within the cranial vault. And then the last type of injury is a primary brain injury, is a vascular injury where there can be some vascular disruption to one of the blood vessels. Obviously, if you have vascular disruption to the subdural veins, then you get subdural hematomas, but you can also have vascular disruption to one of the vessels within the brain, and that can lead to a hematoma, and it could lead to uh, uh, other ischemic injury to the brain. This child, for example, with the frontal contusions, also has ischemic injury to the brain, where you can see the edema and ischemia. So those are the primary brain injuries. And again, we can't do much about that. What we can do a lot about is the prevention of secondary brain injury. And secondary brain injury occurs because of exposure after the injury to a variety of different situations. So if the child is hypotensive because they've got multi-trauma elsewhere, they may have lost blood, or they may have been exposed and in the field for some period of time and they're hypovolemic and they have hypotension, then that leads to reduced cerebral perfusion pressure to the brain, and therefore there can be a secondary brain injury because of that. If a child has a brain injury to the point that they've got airway obstruction, they're unconscious and they've got airway obstruction, then they may have hypoxemia, and that can lead to a secondary brain injury. Or if they've been exposed, they've been lying in a field or in a roadway for a period of time, they may be hypoglycemic, and that can lead to a secondary brain injury. Bleeding, of course, can occur after the injury if the bleeding's not curtailed, and that can lead to secondary brain injury, and as can cerebral edema. So if, just like if you fall over and hit your knee, then the swelling occurs in the first 24, 48 hours. It doesn't occur straight away. Then, of course, the brain also can swell, and it swells within the first 24 to 48 hours after an injury, especially a focal injury. And then if a child has seizures because of the brain injury, then that can lead to a secondary brain injury as well. And then occasionally a cause of secondary brain injury is certainly in an intensive care environment. If we ventilate a patient to a level of carbon dioxide that's very low, less than 30 millimeters of mercury, then that can cause cerebral vasoconstriction, and that can lead to ischemia or secondary brain injury. So we have to target the carbon dioxide level very carefully. The main thing is to understand about that we can't do much about the primary brain injury, but we can do a lot to protect a child from secondary brain injury. And all of our monitoring and our care, our neurocritical care that we provide to a child who's had a traumatic brain injury or any sort of brain injury, whether it's a febrile encephalopathy or meningitis or encephalitis, that they should be focused around the prevention of these complications to prevent any further brain injury. I wanted to just speak a bit about the Glasgow Coma Score, because it's quite useful in, as I said, telling us a lot about the prognosis of the child, and also about the trend of the injury, about the progression of the injury from where further edema occurring or not. And you'll know about the Glasgow Coma Score. There's three components: the motor, the verbal, and the eye-opening component. There are Glasgow Coma Scores that are designed for children, adolescents, and adults, and also modified for infants. And so I won't go through all this now, but the most important component is actually the motor component, and it's probably the only one really that you can assess at the time of the injury if there's been a witness at the injury. So I always ask people who've witnessed an injury, if it's a motor vehicle accident, I always ask them, or if the ambulance officers have just arrived, I always try to find out what was the motor score at the time they arrived. It can be very useful, because if a child is, for example, obeying, or they're localizing to pain, then at the time of the injury, or immediately after the injury, then they will have a good outcome. They should have a good outcome. If, on the other hand, they have no response, so they're having an extensive response, like a 1 or 2 response, then they may not have a good outcome. It doesn't mean they won't, but a child who can obey or localize, they should have a good outcome. And if they have deteriorated, it's because of secondary brain injury, which might be because of progressive edema, or it might be because of a progressive hemorrhage or something like that. So knowing the Glasgow motor score, particularly at the time the child was injured or soon afterwards, can be very helpful. You can assess the Glasgow motor score in infants, and on the right-hand side of this slide, you can see what the modified infant Glasgow Motor Score is. Similarly with the the eye opening and the verbal response, there is a child adolescent eye opening and verbal response, and also one for infants. Now, I won't go through these in detail, but remember the lowest Glasgow Coma Score you can score is 3, and if a child scores 3, they have no motor response, no eye opening, and they have no verbal response. And the highest you can score in the motor is 6, in the eye opening it's 4, and in the verbal response it's 5. And so that gives you a score out of 15. If a child's got a Glasgow Coma Score of 14 or 15, they've got a mild head injury. It doesn't mean they've got it doesn't mean that they don't have any reason for monitoring or to stay in hospital and be carefully monitored. It just means that they've got, generally speaking, a mild head injury. It could be a concussion or it could be a mild head injury. They can still develop complications, but they've generally got a mild head injury. A Glasgow Coma Score of 9 to 13 is a moderate head injury, and they may well have one or more of those intracranial injuries that I mentioned before, such as a cerebral contusion or a diffuse axonal injury. And then a child who has a Glasgow Coma Score of 3 to 8 has a severe head injury, and they almost certainly have one or more of those intracranial primary brain injuries that I mentioned earlier, and they're at high risk of having a secondary brain injury from hypoxia or hypercarbia or hypotension or cerebral edema or bleeding or any other complication. So I just go through this case briefly. This was a 4-year-old boy who was knocked down by a car while walking along the road with his older brother. Now, he was seen to be crying and moving at the scene. That was the only information we had, crying and moving at the scene. And you can see what he looks like. He's got some significant bruising around his eye and around his nose, and his eyes are closed. In the earliest assessment of a child who's got a head trauma, then we do a primary survey, and it's a bit like the airway, breathing, circulation that you do for the triage of any sick patient. And for the airway, it's the same as what you do for any sick patient. You listen for stridor, you examine for blood in the mouth or in the throat, and you look for swelling or any deformity, for example, any facial fractures that might lead to airway obstruction. So you're looking both for, has the child got a patent airway, and do they have an airway that's at risk? They're the main things. The second thing is you do assess the child's breathing, and this child had a respiratory rate of 44 per minute, so a bit elevated. He had mild tracheal tug, and his saturations were 92% on 6 litres of mask oxygen. So he's got some degree of respiratory compromise. He's got no airway compromise. He's got some degree of respiratory compromise. His heart rate was 135, so getting onto circulation. Remember, we said with the circulation, the most important thing you can do is feel the hands and feel the feet, and feel if the hands are cold or warm, feel if the pulse volume is strong or weak, and feel and assess whether the capillary refill is prolonged or normal. They're the most important things you can do on the hands and the feet. You can also measure the child's heart rate and blood pressure, and these were the vital signs this child had. 130 heart rate of 135, so a bit elevated. Again, not surprising given the child had a head injury and was under stress, had cold arms and legs, and prolonged capillary refill. And this child had been exposed for a period of time on a roadway before it was found. Before the brother was able to alert people to get help to the child, but had a blood pressure that was normal. So this child has had some exposure and probably hypothermia, but and maybe a little bit shocked as well. the next thing you do, airway, breathing, circulation, and cervical spine immobilization, and you just try to immobilize the cervical spine so that there is no prospect of ongoing injury. You then do the neurological examination, and that, to start with, that really just that consists of the Glasgow Coma Score and looking for focality, seeing if there's any asymmetry of movement. And so this boy, he was able to localize, so he couldn't obey commands, but he was able to localize. So he got 5 for the motor score. He's eye open to voice, so his eye opening was 3, and he was irritable and cried to pain, but he was quite consolable. He could be comforted. So he gets a verbal score of 4. So that gives him a moderate head injury with a Glasgow Coma Score of 12. So you'd predict from that he may have some degree of cerebral contusion or some concussion, but hopefully he doesn't have a very severe intracranial injury. It's not so severe that his Glasgow Coma Score is very low at the time he's assessed. And remember, he was crying and moving at the scene, so you would hope that he would have a good outcome. If you're using the AVPU score, then he gets V for verbal, doesn't he? He's not very alert, but he responds to voice, so he gets verbal. It's probably better if you can use the Glasgow Coma Score for traumatically injured patients. That's what it's specifically designed for. So your emergency treatment for this child would be to give oxygen by mask, cervical spine immobilization, put in a cannula, pass an orogastric tube. Remember, he's got bilateral. Any child with a traumatic brain injury, you should assume they've got a base of skull fracture at the time they present, even if you don't know. This child's got even more evidence for a base of skull fracture, which we'll talk about. So you should pass an orogastric tube and decompress his stomach because he's likely to vomit. Don't pass a nasogastric tube because of the prospect of a base of skull fracture. And then get a series of x-rays. And in the trauma series of x-rays, which you can get in most places, is cervical spine x-rays, AP and lateral, a chest x-ray to assess the child's ribs and lungs and chest, and a pelvic x-ray. They're the 3 x-rays, and then x-ray any other part that seems obviously affected by the trauma. That requires a secondary survey and a secondary examination. The secondary survey of the head and neck involves, first of all, the secondary survey is an examination of the entire child, but specifically for the head and neck for a child with a traumatic brain injury. Then you're looking for the things that I mentioned before. You're looking for bruises or boggy swellings on the scalp. You're looking for battle sign is bruising over the mastoids. Again, that can indicate a base of skull fracture. This young boy didn't have that, but he did have what's sometimes called raccoon eyes, which are really dark bruises, hematomas around the eyes. So he most certainly had clinically a base of skull fracture. Look for a pupillary reaction. Sometimes you can do fundoscopy. It's not always possible depending on the size of the pupils. Assess the ears to see if there's CSF leak, and if there's any fluid discharging from the ear, you can test that for glucose with a urine dipstick test. The same for fluid coming from the nose. You can test that for glucose. If it's positive for glucose, then it suggests that there is CSF leak from the ear or the nose. And again, that's consistent with a base of skull fracture. And that has implications for how you would manage this child with antibiotics for a period of time until the base of skull fracture is healed. You should look in the child's. The child was only 4 and had some loose teeth, but again, they were infant teeth that had become loose. Look for tongue or mucosal lacerations as part of the primary and repeated as the secondary survey. And then look at the facial bones to see whether there's any evidence of facial bone fractures in any child who's had a head injury. And then assess the child's neck for tenderness or deformity or muscle spasm. Those things shouldn't be done if the child is can be done if the child has spinal immobilization, but the most important thing is to immobilize the spine. Don't be moving the cervical spine around at least until you've got the plain X-rays of the child. And I said the three types of X-rays are the cervical spine X-ray, the chest X-ray, and the pelvic X-ray. So that's the secondary survey. When you're doing a secondary survey of the limbs, then you want to know whether there's any focal deficit, as in, can the child move one side more than the other? Is there some difference in the movements of the limbs? Sometimes there can be relatively a localization with one side, but flexion or extension with the other side, abnormal flexion or extension with the other side. And that suggests focality. When we are assessing the child's limbs in the secondary survey, we want to assess for focality. And then you do the normal neurological assessment of assessing the child's tone and power and reflexes. And sometimes you'll get a very good clue to the presence of an intracranial injury by the presence, for example, of hyperreflexia or asymmetrical reflexes or upgoing planters or presence of clonus. That does suggest an intracranial injury, and important to do those things. But probably the most important aspect of the neurological or limb examination is to look for focality, look for some asymmetry between the sides. When you need to examine carefully for injuries elsewhere, chest and abdomen as well. But mostly today we're talking about brain injury. And next you do the X-rays. And I said the three types of X-rays are cervical spine X-rays, the chest X-ray, and the pelvic X-ray. And I just wanted to run through how to assess a cervical spine X-ray. There is a formula, there's a way in which you can assess it. Sometimes it just looks very complicated to people, but there is a way to assess it. And there's 4 different lines that you need to follow. One is the anterior vertebral body line, the line of the anterior vertebral bodies. And these should be not only straight, but they should be in a line. Sometimes if the child's head is a bit extended, then the cervical spine will be curved, but you can still follow that smooth line. I'll show you in a minute. So that's the anterior vertebral body line. The second one is the posterior vertebral body line, where you looking at the posterior aspect of these vertebral bodies and just drawing a line all the way down the posterior aspect of the vertebral bodies. And that should be a relatively straight line. There shouldn't be too much deviation. And then the third line is the facet joints, and that runs down here, just where the end of this curve is here. And there should, again, be a fairly straight line that runs down here. And then lastly is the spinous process line, which runs at the back of the spinous processes. And it does curve because the spinous processes in C7 and C6 are larger than those of C1 and C2. It curves like that, but it should be an even line. There is one area in children where sometimes we can imagine that there's a gap or a step, if you like, between the vertebral bodies, and that's between C2 and C3. And in this child, this was the X-rays of this particular child, and you can see that there seems to be a gap between this is C1, C2, this is C3 vertebral body, and it looks like C2 is subluxed anteriorly on C3, but actually that's a relative, it's called pseudo-subluxation, and that's a normal finding on a cervical spine X-ray. This is, I've just drawn these lines here, and I'll just try to show you the line. So the anterior vertebral body line, which runs down the anterior aspect of the vertebral bodies, then the posterior vertebral body line, which runs down the posterior aspect, the facet joint line, which runs, again, the black line that runs down where the facet joints all link up, and then the spinous process line. And you can see, again, they all line up in a fairly straight line, or at least it's a linear line without much much overlap between the components of that line. This pseudo-subluxation of C2, C3 is relatively common in children, as I say, but that's the way you need to assess it. This is a child who's got, his neck is a bit extended, and you can see it's all curved, but still is relatively normal. There's the anterior vertebral body line, the posterior vertebral body line, the facet joints, and the spinous processes. It would be much better to have the head in a straight position and the neck in a straight position, but not always possible. The other part of the cervical spine X-ray to look at is the prevertebral fascia and the prevertebral soft tissue. And here, the prevertebral soft tissue is the soft tissue being a bit opaque in front of the vertebral bodies. And you can see the prevertebral soft tissue here that runs down in front of the vertebral bodies, in front of the anterior vertebral bodies. And it runs down to this is the epiglottis here, and then below the epiglottis is the this is retro behind the trachea and in front of the anterior vertebral body. So this is the retrotracheal space, soft tissues, and in front of the anterior vertebral bodies. And what you can see is that the prevertebral soft tissue is quite narrow. It's much less than a third of a vertebral body until it reaches the point of the epiglottis, and then it's still less than one vertebral body in width. And that's the key thing, to look for the distance of the prevertebral soft tissues, because if you've got a cervical spine injury, usually an injury to the ligaments. Remember, in this anterior vertebral body line, there's a ligament, the anterior vertebral ligament, which holds the vertebral bodies together. And if you've got damage to the ligaments, if you've got straining of the ligaments, then or a hematoma or a tearing of the ligaments, then you'll have a hematoma, and the hematoma will fill up this space, this prevertebral soft tissue space, and it'll be much wider. And so where here, this is normal, where as long as the prevertebral soft tissue space is less than one vertebral body, then that's normal. And above the epiglottis, if it's less than a third of the vertebral body, that's also normal. Above the larynx, yes, if it's less than a third of the vertebral body, then that's normal. And below less than one vertebral body, that's usually normal. But it's a big clue to if there's a ligamentous injury or a hematoma or any other cervical spine injury, a fracture as well. Remember that some children, especially young children, are more likely to have cervical spine injury without having a fracture, because they can just tear ligaments. And if they tear ligaments, usually there's some clue in the prevertebral soft tissue space where you get a hematoma and therefore a swelling of that prevertebral soft tissue space. I spoke before about that, the subluxation of C2 on C3. This child hasn't got it, but here there's a more stark subluxation you can see of let's just count them, C1, 2, 3, 4, 5, C5 on C6. And so there's a very substantial subluxation here of the vertebral body of C5 on C6. And you can see that the prevertebral soft tissue space is wider than one vertebral body. And that tells you that there is a hematoma or a major injury to the cervical spine. This child here has another abnormality of the cervical spine, not a fracture, but a distraction injury, where there's a widened space between the cranial vault, the skull, and and C1. And so this is what's called a distraction injury, where this space is wider. So you can hardly see a space here, whereas here there's a widened space. So these are the sort of changes you can see on cervical spine X-ray. And you can see that with this distraction injury, the prevertebral soft tissue space has been obliterated. It's all soft tissue. So there's a major large hematoma in this area here because of this distraction injury to the cranial vault, the skull on C1. So this was the X-rays of this child, and it really just shows normal, the normal C2 on C3 subluxation and normal alignment of the vertebral bodies and normal soft tissues and no fractures. This was the chest X-ray of this child, and even though he had some degree of oxygen requirement at the time he presented, the X-ray is normal without any bony fractures and without any hematomas. But sometimes with head trauma, you can have multi-system trauma, of course, as well. And these are some X-rays of some children who have, this is a child who had a traumatic disruption to the diaphragm, had a traumatic brain injury, but also a traumatic disruption to the diaphragm. You can't see the diaphragm in this X-ray, and he has a traumatic pneumothorax as well. You can see how black the pleural cavity is around the lung. This is the collapsed lung, and so there's a pneumothorax and with a traumatic disruption to the diaphragm, where you'd be worried there's likely to be a splenic injury as well. This is another child who had rib fractures. You can see the rib fractures looking here on the right side. You can see rib fractures where you follow the ribs around. You can't see the ribs in continuity. And because of the rib fractures and the lung contusions, you can see the child's got a hematoma as well. And on the other side, there's also some rib fractures as well. So this child had a flailed chest because of multiple rib fractures. The pelvic X-ray, as I mentioned, you should be looking for areas of disruption. And in this case of the pubic rami, you can see perhaps the fracture here. Remember, the pubic rami is a bony ring. So if you've got one fracture, you'll probably have two. So the fracture is down in the inferior aspect of the pubic rami, and then there's another fracture in the superior aspect of the pubic rami here. So a pelvic fracture as well. So, and here there's a third type of injury, separation of the pubic symphysis, which is another type of injury. So they're the three common types of injuries that children can get from pelvic fractures. So with this child who had a normal chest X-ray, had a Glasgow Coma Score of 11 or 12, was otherwise normal, responding in a stable way. This was the management. He had neurocritical care monitoring. He was nursed at 30 degrees in a head-up position. He was given some analgesia with a small dose of morphine. He was kept nil orally, had an orogastric tube, given some antibiotics, and there was a plan for a review by the surgeons. He was monitored with a monitoring and response chart to monitor his vital signs and other important aspects of his management. And then over the next 2 hours, from being very stable, from responding quite well, he had a dilatation he was noticed on his hourly neuromonitoring to have dilatation of his right pupil that had a poor reaction to light, and his eye was adducted. So adducted wasn't able to be abducted. His left pupil, so his right pupil was 7 millimeters and his left pupil was 3 millimeters. So you've got some asymmetry there. His blood pressure, which had been a bit high when he first came in, not surprisingly, had gone even higher. So to 152 on 112, that's very high for a 4-year-old boy. And his heart rate that had been higher to begin with, 135, dropped to 72 to 76 beats per minute. And by that stage, with that pupillary change, his Glasgow Coma Score had dropped He now only had a flexion response to pain. He could not localize. He had eye opening to only pain. He couldn't eye open to command, and he only moaned to pain. So his Glasgow Coma Score had dropped from 11 or 12 to 7. And so something must have changed. He also was noted to have poor movement on his right side compared with his left side. So he could still move his left side, but he couldn't move his right side nearly as well. And what the question is, what could be happening? This child had a Glasgow Coma Score. He was crying and moving at the scene. He had a GCS that was 11 or 12 when he first presented, it then dropped to 7, and he's got a right pupillary dilatation, and he's got a right hemiparesis. There's something may be happening. And so the question is, what do you do? And if you've got access to a CT scan, then you do that. If you don't have access to a CT scan, then you get the surgeon involved, because it's very likely he's got some progression of a secondary brain injury. And in this case, having been quite stable, it's most likely to be a new hemorrhage. And this was the CT scan of this boy. And you can see that from being very stable, he's got this is an extradural hematoma. I showed you some subdural hematomas in the past, just before, but this is an extradural hematoma. It has a concavity about it, and it's also quite bright. An extradural hematoma will always be bright white, whereas a subdural hematoma sometimes will be darker because it's older. This is always an acute event. It's always usually just happened. Sometimes it'll happen at the time of the injury and then progress over the next couple of hours, as this one did. And you can see that it's a large extradural hematoma, and that's putting pressure on his on the right side of his brain. And he's got this is left and right, and he's got what we call mass effect, or there's the mass effect, which is it's supplying pressure on the right side of his brain, and it's compressing it to the left. So what to do in that circumstance? Well, seek urgent help, isn't it? You need a surgeon, a neurosurgeon ideally, but a general surgeon can drain an extradural. You need to cross-match blood urgently, get a hemoglobin, a glucose, a coagulation if you can, give the child a blood transfusion, and organise for surgery urgently. That's the only thing that will help this child, because you're not going to be able to stop this extradural hematoma without actually evacuating the clot and stopping and that's exactly what happened. This child had an urgent by a general surgeon burr hole that drained the extradural hematoma, and this child did very fine after that. Usually you can see the rest of this child's brain looks pretty normal. There's a bit of edema, but that usually resolves very quickly after you drain the extradural hematoma, as it did with this child. So he got back to having a GCS of 12 or 13 and then recovered over the last couple of days, the following couple of days. If a child has a complication like that, then you need to get, as I said, it's a multidisciplinary approach. You need a surgeon. Ideally, you need an anaesthetist, or you need to have the skills to be able to manage this child's airway and breathing and prepare the child for surgery. And I think it's within our skill set to be able to resuscitate a child like that and prepare them for surgery. And that requires what's called a rapid sequence intubation. If you've got an anaesthetist there, then that's ideally that they should do it. But you need someone who's a skilled intubator of a child to do that quite promptly. You need the right equipment, so a bag and mask, the right size laryngoscope, the right size endotracheal tube. Ideally, you need a Yanker sucker, which is a hard suction catheter, not a flexible one. It's okay if that's all you've got, but there are plastic catheters called Yanker suckers that are easier to use. You need oxygen, of course. You need in this setting, I always have some other tools too. So either a stiletto to go in the endotracheal tube if it's a young child, or a bougie that you can intubate the child with before you put the tube in, just in case things are difficult, just in case. Usually you don't need it, but if you're prepared, that's good. The drugs I would use for a child who's had a head injury, usually a small dose of thiopentone, so 2 to 5 milligrams per kilogram given slowly. Remember that thiopentone will cause hypotension, but if you give it slowly, it's less likely to. In a child with raised intracranial pressure who's got bradycardia, I always have some atropine ready and be ready to give that or even give that. And a muscle relaxant, you choose the muscle relaxant. It could be rocuronium or vicuronium or succinylcholine. Always before you intubate a child, or ideally if they're cold and they're a bit shut down, then have a fluid bolus running and have adrenaline ready, but usually certainly give a fluid bolus and have it running at the time that you're anesthetizing the patient. You need skilled assistants to do that. You need other people who are a bit trained in, especially the head positioning. I think that's the most important thing. And sometimes manipulation of the cricoid cartilage to give you a good view of the larynx. After you've intubated the child, you ventilate them in 100% oxygen and aiming for a carbon dioxide level that's not too high and not too low either. So 30 to 35 is okay. Less than 30 is too low and will cause vasoconstriction, and above 40 may not cause cerebral edema, but it won't help the child's intracranial pressure. So aim for a carbon dioxide level of 35 if you can. Some people give mannitol in this situation. If there's an intracranial hemorrhage, then it's better not to give mannitol, because mannitol can reduce cerebral swelling, but that can only encourage, in this circumstance, in this acute circumstance, it can encourage an acute extradural to get larger because it makes more space within the brain. So usually this is the only circumstance of raised intracranial pressure where it's not ideal to give mannitol. As I said, this child had that. The child was able to be intubated, had urgent surgery, and actually in the ward, and then was able to be recovered quite well in the coming couple of days, and then got back to normal, all because of the good monitoring and the ability to identify a complication of what was a moderate head injury to begin with. The indications for tracheal intubation of a child with traumatic brain injury, they're standard and they're obvious. If a child's got severe hypoxemia despite oxygen, if they're not hypoxic when you give them oxygen, that's fine. You just give them oxygen, that's all. If they've got respiratory failure due to inadequate ventilation, like if they're in a coma and they're not breathing up adequately, if they're not generating adequate tidal volume, then they need to be intubated and they need their breathing helped. Or if they've got airway obstruction, and often it's a combination of both, that they've got depressed respiration because of their comatose state and they've got some airway obstruction, and those children need to be intubated and ventilated. If they've got a GCS, Glasgow Coma Score, of less than 8, then ideally they should be ventilated, because most likely they've got a serious intracranial injury, like I said, a serious primary brain injury. And if they're needing surgery, then of course they need to be intubated. I remember I said at the start that most head injury is mild or moderate, and as paediatricians, we need to be able to deal with and manage concussion, because that's a relatively common condition, but it's not a trivial condition. Often we think concussion is minor, but actually it can be something that can last for several weeks. And this is important to understand. And the features of concussion can be rather similar to the features of a serious brain injury, but a child with concussion won't have any of the features or any of the other features of a serious brain injury, as in they won't have any abnormal neurological examination, they won't have any focality, they won't have hypertonicity, they won't have upgoing planters, they won't have a hemiparesis, they won't have pupillary deviation, etc. They'll simply have the features of concussion, which can be like vomiting is common, headache. Children often have a headache if they've got concussion. They may feel like they're in a bit of a fog. If they're old enough to be thinking normally, then if they're old enough to be thinking, they may not feel like they're thinking normally. They've had a knock to the head and they're just not thinking right. They may have balance problems or dizziness. They may be quite bothered by light or noise. They may feel a bit confused, or they may have, if they go to school, they may have difficulty concentrating or remembering things. That's very common to children if children have concussion, and it can last for several weeks. They may have slowed reaction times. So certainly if children have concussion while they're playing sport, they shouldn't be playing sport for until all those features have resolved, because they won't be able to react in the same way, and they're prone to secondary injury. They may be upset or moody. Sometimes parents say that's what they're like at times, and these symptoms can last for several weeks. They may be gone in a week, but they may last up to sort of 3 to 6 weeks in a child with significant concussion. And our job is to make sure that they don't have any other features of a more serious brain injury that would require surgery or some other treatment. And it's really a matter of doing a proper neurological examination and making sure they don't have those other features that I mentioned of a serious brain injury. For a concussion, you don't need to do scans if there's been no loss of consciousness and no abnormal neurology. Usually I often observe them over a 24-hour period, and if there's no neurological abnormalities occur in a 24-hour period, then they're usually pretty safe to go home. Most concussions will get better over a few days. They'll just sleep it off, if you like, but often they can take up to 4 to 6 weeks to recover, and you need to tell parents that. But it's very important to observe them, because the features that I showed you with the case that I presented, that of extradural hematoma on the back of on top of a moderate brain injury, can occur even in children with concussion. It's usually if they've had a loss of consciousness at the accident, like if they've been on the rugby field and they've had a loss of consciousness and they get brought to the hospital, then they need to be monitored for at least 24 hours to make sure they don't have any complication of a brain injury. So you can manage most of these patients without doing scans. You simply just need to do a good and serial neurological examinations. All right. Well, that's all I want to say today about acute traumatic brain injury in children. I hope that's been useful, and I'll stop sharing my slides and stop the recording now and take any questions that you might have.